mentioned are just for learning purposes. So feel free to use those, Kayleigh, because I know it's easier for people to recognize brand names sometimes. And I don't think that Kayleigh has any disclosures, or anyone else on the call has any disclosures that's been presenting anything.
Nope.
And then the Mid-Atlantic AIDS Education Training Center, or MATEC, we're based here out of, we have several different sites throughout the Mid-Atlantic region, but we are the West Virginia site, so we serve the entire state. And then there's some additional resources there, the National HIV Curriculum and Consultation Center. You can feel free to look at those if you'd like at a later time. Yep, I think we're just down to the no disclosures.
Gotcha. All right. Yeah, my name is Kayleigh Berner. I'm a nurse practitioner. I introduced myself at the beginning of the call, but I'm an APRN with infectious diseases at Ruby Hospital with WV Medicine in Morgantown, West Virginia. I am going to spend some time talking specifically about HIV pre-exposure prophylaxis medications. So I won't be talking about comprehensive PrEP care today, just for in the sake of time. But today's objectives, we're going to define HIV PrEP, discuss the current literature surrounding PrEP, describe and compare available forms and dosages of PrEP, and then review clinical considerations when prescribing. And then if we have time for questions, certainly I'm happy to answer those after, or my email is also at the end of this slide set too, if anyone wants to reach out with me, reach out to me with more questions. So pre-exposure prophylaxis, it's one component of the HIV preventative care continuum and a key prevention strategy for ending the HIV epidemic in the United States. And it's part of a comprehensive prevention plan. So medications, such as those we'll be discussing today, prescribed in conjunction with risk reduction counseling, STI testing, syringe services, etc. It's the use of antiretroviral medications that are intended to prevent HIV acquisition by uninfected individuals at risk. And so risk would be either via sexual contact or IDU or injection drug use. And we have both oral and injectable options approved. HIV PrEP is initiated before and then continued throughout periods of potential exposure to HIV. So this is different from HIV PEP that is administered as a 28-day antiretroviral course to be taken after an HIV exposure. So this is something you take prior to potential exposure. This is a list of trials that have been conducted. Oh my God, my lights went out. Hold on a second. There we go. This is a new office and it's not doing me well right now. So PrEP efficacy has been evaluated in many clinical trials. I do want to point out, so the most robust data is going to be with cis men and transgender women who have male sex partners. There's also a pretty good data profile with heterosexual men and or women, cis women, who are at risk for HIV, either serodiscordant couples, so they have an HIV positive partner and an HIV negative partner, or those that are at high risk. There's only one study that was conducted for individuals who inject drugs. So that's something else that I want to point out, is the literature is not as robust there. And then also trans men, like I said before, they're not significantly represented in any of these trials. The why behind that is that transgender individuals only make up about 2% of new HIV infections a year. And of those, 92% are transgender women. And so there's just not a lot of, there's just not a large population to study. So what the majority of these studies have concluded is that PrEP is highly effective at preventing HIV. So up to a 99% risk reduction with sexual risk, and then at least a 74% risk reduction with injection drug use risk when taken as prescribed. What these studies have also shown is that drug levels, oh God, go back. How do I go back? Drug levels correlate with a protective effect. So in the Partners PrEP trial, overall, there was a 75% risk reduction of HIV, but in those that had detectable measured drug levels of tenofovir, there was a 90% risk reduction. With the iPrEP trial, overall, just a 44% risk reduction in the FTDF arm. So the brand name, and as Alyssa said, I tend to refer to brand names just because it's not as much of a mouthful. So this is FTDF is the brand name Truvada, but there is a generic available. And so there was a 92% risk reduction in individuals that had detectable levels in the iPrEP trial. And that trial included men who have sex with men, so cis men and trans women. The Bangkok tenofovir study, so this was the sole study that looked at injection drug use as the risk factor. There was a 45% overall risk reduction, but 74% risk reduction with patients who had detectable drug levels. This data doesn't look offhand to be that great with IDU. However, I do want to point out that in this study, they were only using tenofovir disoproxil as the PrEP medication. Whereas the treatments that are approved or the therapeutics that are approved, they are actually co-formulated regimens. So it'll be tenofovir, either disoproxil or alafenamide, plus another NRTI, emtricitabine. So we may see more effectiveness using more than one drug is what we would expect. So that would be the limitation of that study. The other big thing that I like to really point out is that there is a lot less forgiveness for missed doses among cis women than men who have sex with men. And particularly when I refer to that, I mean a vaginal receptive risk factor than if we're talking about anal insertive intercourse or anal receptive intercourse. There was a strand trial, which was kind of a subset of the iPrEP data model that measured tenofovir disoproxil concentrations in men who have sex with men and transgender women. And even if those patients only took 2 doses a week of PrEP, they still conferred 76% risk reduction. If they took 4 doses a week, they still conferred 96% risk reduction. With cis women or vaginal receptive risk, there's been some pharmacokinetic studies that show that there are a lot lower concentrations in lower vaginal tract tissue that are sustainable than there are in rectal tissue. And so really, with a vaginal risk, you'd have to be taking 6 of 7 doses a week in order to confirm adequate protection. So just be aware of that as well. There is some forgiveness for missed doses with men who have sex with men, but not with a vaginal receptive risk. So the CDC, DHHR, and DHHR released a PrEP clinical practice guideline update in 2021 that recommends all sexually active adult and adolescent patients should receive information about PrEP. So we should at least be telling all of our patients this is a thing. And then PrEP prescription should be offered to all adults and adolescents who weigh at least 35 kilos, so 77 pounds, who either request PrEP regardless of their reported exposure risk, report events that carry a risk of HIV exposure, and that's whether we're talking about sexual or injection drug use related events, present with a bacterial STI in the last 6 months, or present for HIV post-exposure prophylaxis. And so for our 2 cases presented today, we had 2 patients. One was requesting PrEP, maybe didn't feel comfortable disclosing what their specific risks might have been, but we're still requesting, so we should be offering. And then also our second patient presented with a bacterial STI and also had sexual and injection risk factors. So in order to even be eligible for PrEP, first steps are you have to determine that the patient is HIV negative. PrEP is contraindicated in individuals with an unknown or positive HIV status. You have to have documentation that the patient does not have HIV when they start taking PrEP medications. So ideally, this is going to be our preferred testing modality is going to be based on exposure history and prior PrEP use. If the patient has not been on PrEP previously, so with oral PrEP in the last 3 months, with injectable PrEP in the last 12 months, you can check a serum HIV antigen antibody, which is the preferred, it's a serum test, or you can also do a point of care blood rapid test being the HIV antigen antibody, plus also sending a serum HIV antigen antibody as well. If the patient has been on PrEP recently or is continuing on PrEP at baseline, you should be checking an HIV antigen and antibody plus serum HIV RNA assay, which is a nucleic acid test, or the HIV viral load. If the patient is starting PrEP, you want to have a negative HIV test within 7 days of when they start. If the patient is starting on injectable PrEP, you want to be checking HIV testing either the same day that you're starting the injection or just a few days prior. HIV antibody testing alone is not going to be sufficient to initiate PrEP, and that's whether you're doing like an oral rapid test or a home test, because those are available over the counter now, or even a serum antibody test. That's not sufficient to initiate PrEP because that time to positivity for an antibody test is much longer than with an antigen antibody or a viral load. In addition, the patient must not exhibit signs or symptoms of acute HIV infection on the day of evaluation or in the preceding 4 weeks. And if the patient reports an HIV exposure within 72 hours of presenting, then you want to evaluate the potential need for non-occupational post-exposure prophylaxis. And then you can consider directly transitioning them to PrEP at the conclusion of that 28-day NPEP course. So our PrEP medication options, we have 2 oral options, and then we have 1 injectable option. Currently, the 2 oral options are emtricitabine plus tenofovir disoproxil fumarate. This is given as a combination pill, and it is 1 tablet that would be taken once a day. This is indicated to or recommended to prevent HIV among all people at risk through either sexual, so all sexual risk, or injection drug use risk. Brand name for this is Truvada. Again, there's also a generic available. There's also FTAF, which is emtricitabine, again, co-formulated tablet, plus tenofovir alafenamide. This is recommended to prevent HIV among people at risk through sex. So this excludes people at risk through receptive vaginal sex. There's a study that the manufacturer is currently conducting on receptive vaginal sex. Why this is happening. But that data is not yet available. Injection drug use risk has not been studied with FTAF, or the brand name for that is Descovy. And then injectable PrEP, we have 1 option. It is cabotegravir, so long-acting cabotegravir. It's given every 2 months as an intramuscular injection by a healthcare provider. And this is recommended to prevent HIV among all people at risk through sex. But again, injection drug use has not yet been studied. There's another medication that's coming through the pipeline. It's still being studied for PrEP, but it's an injectable sub-Q, so subcutaneous injection that's given every 6 months, called Lenacapavir. So that's not something I'll discuss today, but that's something that hopefully will be available pretty soon. So with oral PrEP daily dosing, I'll talk about Truvada first. It's a 200-300 milligram tablet, 1 tablet once daily dosing. There is an on-demand dosing option for men who have sex with men. Approved again for adults and adolescents weighing over 35 kilos. It's recommended for all persons at risk, whether it be sexual or injection risk, and/or. And it's approved with a creatinine clearance greater than or equal to 60 milliliters a minute. Things to know. So when I discuss this with patients, I relate it as similar to the concept of birth control. So you're not going to take your first dose and it's going to be immediately effective. It really takes 7 days to reach maximal effectiveness for receptive anal intercourse. But for receptive vaginal sex and injection drug use, it's actually takes a little bit longer to reach maximal protective levels. So we say to take it for 21 days before you can be adequately protected with PrEP. And this is with oral PrEP. The on-demand option or 211 PrEP, you might have some patients that ask you about this. I don't tend to discuss this offhand unless one of my patients brings it up as an alternative. It's seasonal PrEP or event-driven PrEP. So one scenario for this would be if you have a patient who, let's say they only engage in high-risk sexual behavior if they go on vacation. Otherwise, they're not. So they may not need to be taking PrEP every single day. They can do it more event-driven. Only FTDF or Truvada has been studied, and there's no data outside of MSM. It's not FDA approved. It is described in the US guidance, and this is based on European trial data. It's indicated for insertive sex and then receptive anal sex, not vaginal receptive, not injection drug use. This is for individuals who request non-daily dosing or have infrequent intercourse and can anticipate or delay sex to permit the dosing schedule. It's given as 2 Truvada tablets, 2 to 24 hours before a sexual encounter, followed by 1 tablet 24 hours after that first dose, and then 1 tablet 24 hours after that second dose. So 2-1-1 dosing. If a patient continues to have sexual events that occur more than 24 hours after their first dose, they just keep taking daily PrEP until 48 hours after their last sexual encounter. It's off-label, and it's not, again, not been studied with receptive sex or IDU. And this method should not be used for individuals with Hep B infection or for those who have difficulty adhering to a complex dosing regimen. And that's really because tenofovir treats hepatitis B. So if you have somebody that's just intermittently taking Hep B treatment and they have a Hep B infection, you could inadvertently be inducing a flare when they stop. It's also, how do I go back one? Oh, Kelly, can you go back one slide? There we go. Also, it's not recommended if a patient with transgender women who are receiving gender affirming hormone therapy, so particularly estrogen, that can actually reduce tenofovir levels a bit. If they're taking daily tenofovir, it hasn't been shown to significantly reduce enough to make a difference. But if they're just taking intermittent PrEP, it could reduce it low enough that it's not effective. So this is a schematic for the on-demand dosing. The reason I'm not sold on this method, number one, it's not FDA approved. The main reason is that the studies, in the study data with the European trials, the patients that were using this method on average were taking 3 to 4 doses a week anyway. And so if you remember that data that I showed at the beginning, that there's a lot of forgiveness with non-adherence for men who have sex with men. So if they're only taking 4 doses a week, they still have 96% risk reduction for HIV transmission. So if you really have somebody that's only taking this intermittently, let's say like twice a year or 3 times a year, we don't really know if it's going to be effective, right? There have been some breakthrough cases of HIV using this method. And so it's not something I'm sold on. I've used it a few times, but I don't kind of readily endorse it. Oh, I think I lost control of the slides. Kelly, can you just advance them? Okay. The other daily option for oral PrEP is going to be FTAF. It's a 200-25 milligram tablet. Can you go back a slide? Yeah. Brand name is Descovy. This is not available yet generically, but 2026 it should be. Again, 1 tablet, once daily dosing. This has not been studied with that 2-1-1 method. It's approved in adults and adolescents, again, weighing over 35 kilos. Efficacy compared to the TDF co-formulation has shown that it's non-inferior, and it's approved for individuals at sexual risk, except for those at receptive vaginal sexual risk. The appeal to this is that it's marketed as being more protective, renal protective. And so it's actually approved with a creatinine clearance as low as 30 milliliters per minute. So if you have somebody that already has underlying renal disease, this may be a better option for them. Again, 7 days to reach maximal effectiveness. Next slide. Okay. So clinical pearls with oral PrEP. You want to be doing HIV testing every 3 months, so at baseline, and then every 3 months in order to provide refills, because you're giving a partial HIV treatment regimen. So if you end up, the patient is not adherent, or in some cases, again, this is not 100% effective, but if they do develop HIV while on this medication, they're not getting screened, then they actually can develop resistant HIV virus. FTAF, so Descovy is preferred over Truvada if there's underlying renal or bone risk. So the Truvada, it can potentially cause renal toxicity. There's about a 1 to 2% reduction in bone mineral density with FTDF that is reversible once that drug is cessated. But if somebody is already on like high dose steroids or has osteoporosis or any kind of pathological bone issue, you may want to do FTAF instead. Truvada would be preferred over Descovy if a patient has underlying metabolic disorder or cardiac risk. So with Descovy, you want to be monitoring lipid panel annually. It can increase triglycerides and LDL. Also, there's been some associated weight gain as well. So you may want to prefer Truvada over that with those patients. In addition, make sure you're documenting Hep B status at baseline and then vaccinating if they're susceptible. If you have somebody that has active Hep B and you're giving them a tenofovir-based regimen for PrEP, if they decide to just stop it, there's that risk of Hep B flare on discontinuation. And then injectable PrEP, again, cabotegravir is the only option we have. It's given as 1 3 ml injection. It was approved December 2021. You want to be checking HIV antigen antibody and HIV RNA testing at baseline. And that's because there is once you're on this medication, it actually delays seroconversion for quite some time. And so your antigen antibody test is not going to turn positive as early as it would have if they were not on cabotegravir. So you really need to be checking both the screening and the viral load at baseline and with every injection. Again, adults and adolescents weighing over 35 kilos, not studied or approved with those who inject drugs. It's given as a single dose IM, second dose given 1 month later, and then subsequent injections every 2 months thereafter. There's an oral lead-in option that really would only be indicated if a patient's concerned about side effects and wants to just try the oral before they're committing to the injection. So the big things with injectable PrEP to know is there's what we call a tail phase. And so what this means with the schematic, so you give the first injection, the cabo levels increase, and then when they're close to getting their next injection, those levels wane with time. So each time you give that injection, those levels rise again. If the injection's either not administered on time or that injection is discontinued, those CAB levels will actually wane over several months, actually can be detectable even up to a year after. Eventually, they're going to fall below the protective threshold to prevent HIV and really persist for some time at non-protective levels. So the danger with that is that a patient's going to have lowly detectable CAB levels, but if they get exposed to HIV, it's not going to actually prevent infection, and then they can develop HIV-resistant infection. There's also a short, a pretty tight window of administration period. It has to be given 7 days before or 7 days after their target administration date. And if you discontinue this medication and they still are at risk for HIV, you really need to be transitioning them to oral PrEP because of that potential, that tail phase. Clinical pearls, I basically went through all of these. If you do stop injectable PrEP, they still need to follow with you quarterly for the next 12 months. And that includes getting HIV testing quarterly for the next 12 months, even after stopping because of that long tail period. And then I'm just going to go through, I think maybe 1 or 2 more slides so everybody can get out of here. But this is just a summary of side effects and safety. So all 3 types of PrEP are generally well tolerated. Side effects are usually mild or moderate. They're manageable and temporary. So with Truvada or FTDF, as well as FTAF, we tend to see what's called startup syndrome. It happens in less than 10% of patients, but it's a constellation of headache, nausea, abdominal pain, usually just within the first few doses, tends to go away after that. In some patients, it can last a month. It always goes away, though. It's just them getting adjusted to the antiretrovirals. We don't see this with the injectable. The injectable side effects we tend to see are your typical injection site reactions. So some pain or tenderness, some localized skin swelling, and it tends to be mild and brief. With FTDF, remember you're monitoring kidneys. There can be a small decrease in creatinine clearance. And then with FTAF, this also can happen. So you still want to be monitoring kidney function, but it's less likely to occur. With Truvada or FTDF, there's small decreases in bone mineral density. It's not been associated with fractures, but just be aware if somebody also has underlying bone issues. And we don't see that with Descovy or the injectable. And then monitoring weight and lipids if they're taking Descovy. And then just a quick slide about PrEP use with conception, pregnancy, and breastfeeding. Certainly the risk for HIV transmission and complications is going to be much higher than any potential risk of utilizing PrEP during pregnancy or breastfeeding. So the main thing to know is that if the patient has an HIV positive partner, their partner needs to be undetectable on antiretrovirals. That's going to permit the least likelihood that they'll transmit HIV. And I think that's where I'm going to stop because I just have some drug interactions. Honestly, I recommend you go through drug interaction profile with any medication you use, so I won't spend time on that. And then the last slide that I had was just lab monitoring for oral versus injectable, what we don't typically need to monitor with PrEP. And I think that's it. PrEP care should be really covered since it's preventative. Any questions before everybody goes? Yes, the slides will be made available. That's why I kind of flew through the last few because they will be available for your reference. Kelly will send those out. And then any other questions?
I think there's another question in the chat, Kayleigh.
On
the impact about the medication.
Is there any information about the impact about the medications on HIV testing? Yes. So there is with both oral and injectable PrEP, HIV antigen antibody testing, there is that delayed seroconversion. So with oral PrEP, it tends to be only about 30 days, give or take a few days, that it would delay their test time to positivity. With the injectable PrEP, it can be like 60 to 90 days. So that's really why you're checking the viral load every single time you give that injection so that you're not missing incidental HIV infections. Anything else? Thank you guys. I appreciate everyone hanging out here and joining. And so we'll certainly keep revisiting these. I just wanted to at least introduce everyone to the medications, and then we will, yeah, Trina put, unfortunately, Ready Set PrEP stopped in July. So yeah, I don't think I updated that slide, but that was a free program for PrEP medications. It didn't pay for the labs or office visits, but it did help us get access to PrEP for those that were uninsured. I will say that the generic Truvada is available for $16 a month. So, I mean, it's pretty affordable. So even without Ready Set PrEP, I mean, there's still an option for prescribing that's not going to be costly. And if that's it, I'll let everybody go.
Sorry.
Yeah.
Thank you so much for presenting, Kayleigh. Our next session is going to be on HIV testing, and that's going to be by Andy Rogers on October 3rd. So I look forward to seeing everyone then, and thank you, Kayleigh, for your time, and thank you to both of our case presenters.
Thank you all so much, and have a great rest of your week.
You as well.